Thank you, Mr. Chairman. Dear colleagues, I would like to thank the organizing committee for the honoring invitation. I don't have any conflict of interest to disclose. So the patient we're presenting to you is an 89-year-old woman with a past medical history of hypertension, dyslipidemia, and atrial fibrillation, which was referred to our center for, due to severe aortic stenosis, symptomatic. The echocardiography revealed a preserved systolic function of the left ventricle and a severely calcified aortic valve with a mean pressure gradient of 50 and aortic valve area of 0.7 square centimeter. We proceeded with a TAVI workup. Coronary angiogram was unremarkable, just a mild distal left main disease. And here are the three-dimensional reports of the TAVI-CT analysis. As you can see, the annulus is quite small, with an area of 384, a minimum diameter of 17.9, and mean diameter of 21.9. There is severe calcification of the aortic valve extending to the LVOT, as you can appreciate in this image. And here you can see some images of the aortic valve. And you can notice the severe calcification of all leaflets, especially of the right leaflet. Regarding the peripherals, they looked relatively good with acceptable dimensions. There is some moderate calcification, but no significant tortuosity. So taking into account the relatively small aortic annulus, the LVOT calcification, we opted a supraannular valve. And as you can see, according to the annulus perimeter, the most appropriate for the Evolut Pro Plus platform was the 26-millimeter valve. So our setup was the usual, mild sedation, local anesthesia, primary access ultrasound-guided puncture of right femoral artery, plan for closure with 2 prostyles, secondary access left femoral artery, 6 French, and pacing over an RV temporary pacing wire. We plan to perform pre-dilatation with an 18-millimeter balloon, respecting the minimum aortic annulus diameter. As you can appreciate, there is significant calcifications. There is also AR. Valve creaming looks good. So we started with a pre-dilatation of the valve with an 18-millimeter ZMed2 balloon. And we proceeded with our first deployment attempt. So this was the result of our initial deployment attempt. You can notice that it's a quite high implantation, perhaps acceptable, but since our plan was to perform a post-dilatation for this valve, we thought that it would be better to go a little bit deeper to avoid any aortic embolization during post-dilatation. So we recaptured the system and performed a second deployment, a little bit deeper. And after the initial 8% deployment of the valve, we noticed this severe under-expansion of the inflow of the valve, which was not present during our first deployment attempt. So one should think what to do with this image, what should be our next step. The patient was a little bit unstable at this point. We took another view, an LAO view, where you will notice that there is this vertical line present here, which is very typical of valve infolding. So we decided to recapture the valve and remove it, and this is how the valve looked like after unsheathing it outside the patient. So it's a typical infolding, which is very rare for 26-millimeter valve. Perhaps this was caused by this severe calcification, especially of the right cusp, during the resheathing attempt. So we got a new valve. We did not perform any further pre-dilatations. We got a new valve and performed a slightly deeper implantation. This was the result after valve deployment. still a high implantation. We performed a post-dilatation with a 20mm balloon, and this was our final result with some mild PVL. Hemodynamics were good. Access closure with 2 prostates was successful, and the patient was discharged 3 days later. So we present this case just to stress the importance of recognizing this although rare, but potentially life-threatening complication of prosthesis in folding, which is very uncommon, especially with smaller valves. Risk factors that should be in mind, we should keep in mind, are severe native valve calcification by Casper anatomy, implantation of larger valves like 29 or 34mm for the Medtronic system, receding attempts, and early diagnosis and treatment are of paramount importance. Signs of prosthesis in folding should be angiographically excluded, potentially with a second view, before full valve release. In case we did not notice this complication and release the valve, urgent post-dilatation is the only option. Otherwise, if we recognize this problem, we should recapture and remove the whole system and get a new valve. Think of a new pre-dilatation and perhaps choose to perform slightly deeper implantation during our second attempt in order to give more space for valve expansion. Thank you very much for your attention.
Very nice presentation. It's a rare problem, and not even with a 29. Usually it's a problem with a 34 Evolut Pro.
Yeah, exactly. In a large series, 94% of the cases of infold were with Evolut Pro Plus 34.
Exactly. And you must be careful when you are going to see the valve, when you are going to fold the valve during the second implantation, not during the first implantation. It's a very rare problem, and you must care a lot about it. I think that we can, during the first Friday presentation from Moulias, you have present a case like this with a 34 valve, if I remember well. Okay, let's proceed with the 3 moderators. Dr. McGuinness.
Congratulations. Very nice. I agree with of you removing the valve and see what's going on. And I think we need more data to understand the mechanism of this phenomenon. It wasn't there in the first deployment and happened in the second. I think we should understand what exactly happened, not because of your maneuvers, but because of valve behavior. And I agree with everything you did. You had a very good result. The calcium is the reason of all this malfunctioning, and your pre-dilatation was good. So I think it was a rare event that you really did exactly what you should do.
Thank you.
Thank you.
Professor Tsikas.
Congratulations, Thanasis, for this excellent demonstration. 2 comments. Why not to use a BEV in this strange anatomy with these strains annually full of calcium? We know that calcium is a general enemy, I could say, for TAVI procedure. We have to prepare better the valve. And why not to use a bigger balloon, just to prepare better, to avoid such conditions? Only a comment for that. We know that we discuss all the cases before the procedures, but there are always concerns, especially after the case of if we face problems, and we have to learn, all of us, from these conditions.
Okay, thank you very much. Dr. Taleb?
Congratulations for the case. I would just do a general comment. You managed this very, very well. But generally speaking, anytime we try to deploy a self-expanding valve, even if we have the ability to recapture, we should always target to release it once and for good, as if we are doing a balloon expandable valve. Obviously, we have this ability to recapture it and reposition it, but this is something that we should aim to avoid at any cost, the recapturing process.
Yeah,
we should move on forward.
I totally agree with you, but it was a zero depth implantation,
no,
so we worried for potential.
You managed it perfectly.
Okay.
This is just a general.
Okay.
Thank you.
Dr. Sparigas has a comment.
Just a comment, because we had a similar case that we've presented in the TAVI rounds a few months ago, that was a bicuspid valve with a lot of calcium, and it was a large valve. And when we arrived to the point that we saw that the valve was oval with that compression from the raphe, the calcified raphe, and it wasn't obvious that it was an infolding. It was just compressed. So we released the valve, and the infolding happened after with the post-dilatation, because the anatomy was so strained, so that calcium in the raphe pushes towards one direction, and this caused the infolding. Fortunately, it was very distal and was not affecting seriously the function of the valve. I like to emphasize what Adam said. Although we have the option, the possibility, the potential to recapture, to receive, to reposition, we should avoid to do that. We should try to be direct and successful with the first attempt, because these patients, although we discuss in the meetings nicely these cases and we're proud of the result, these patients sometimes they became unstable, and then you have to act quickly. And you said that your patient became unstable, so you kept your temper, you removed the valve, hopefully the patient stayed stable. But some patients with severe aortic stenosis, with low ejection fraction, things like that, they become unstable and you cannot stabilize them. So speed is very important then, and that's why we should always balance the positives of the valves that you can recapture, receive, and all this stuff, versus the valves that they are one and for all, like the balloon expandable or the accurate valve, that you go and you quickly act. Just food for thought.
Okay, thank you very much, Dr. Sparios. Dr. Manginas?
Because infolding can be life-threatening and has complications to remove the valve, to reposition it, I think we should study infolding better because there are no real studies in relation to the calcifications.
Of course, yes, you are right. Okay, thank you. Thank you, Dr. Moulias. It was a very